Well, hello,
Hi.
everyone. Thank you all for joining us today. My name is Keith Pearson, and I'll be the moderator for today's discussion that's titled Enteral Nutrition for ALS, Interdisciplinary Coordination for Successful G2 Placement, presented by Michelle McDonough. Michelle is a practicing registered dietitian at Froedtert Hospital in Milwaukee, Wisconsin. She has worked at Froedtert since moving to the area from Ireland in 2008 and has since developed her own brand of a Wisconsin Irish accent. Michelle earned a Bachelor of Science degree in Human Nutrition from the University of Ulster, Northern Ireland. She holds a post-baccalaureate certificate in dietetics from Mount Mary College in Milwaukee. And her passion for nutrition advancement has led her to present for the American Speech and Hearing Association, the Wisconsin Parkinson's Association, the NEALS Consortium, the ALS Association, the International Symposium for ALS MD, and NACFC. Michelle specializes in the care management of patients with CF, diabetes, and ALS. So today we'll have a Q&A discussion at the end of the presentation, and we want to foster a robust discussion. So we encourage you to raise your Zoom hand during the Q&A time, and we will call on you to unmute yourself to ask your question and share your experience. I also want to remind you that if your display name does not match the name that we have for you, please type your name in the chat so we can ensure some proper attendance records. Also, in a second, I'll attach the CPE certificate in the chat box. And so in order to claim CPE credit, we must have an evaluation. So we ask that you please complete the 4-question evaluation at the end of the session. And so lastly, we want to thank the ALS Association for providing the Quality of Care Program grant to support this presentation. So with that, I'll hand it over to Michelle. Michelle, you can share your screen and get going.
Well, thank you for that kind introduction, Keith, and thanks to Stephanie Doback as well for inviting me to speak on this topic today. So we're focused on the interdisciplinary coordination for successful G2 placement. We can move along through here to the next slide, and then I don't have any financial relationships to disclose. So we can just move along to objectives. So the objectives of the presentation today are to identify the diverse healthcare disciplines involved in successful feeding tube placement and discuss common difficulties that can occur in coordinating tube placement before, during, and after care, and emphasize the importance of having a process in place to ensure patient safety, promote quality of life, and avoid miscommunication, making sure we are all on the same page. And this could even just be a simple checklist of points where issues have occurred or issues or points of contact where issues could occur. So while I'm going through my slides, I would encourage everyone to kind of think back on patient cases where you felt like things didn't go exactly right in working them up and educating and the whole feeding tube placement process. And then on one of my later slides, I have a couple of issues that I've encountered that I'd like to share too in our discussion. All right, next slide. So Stephanie had mentioned that we have, quite a few newer dietitians to ALS. So I just wanted to level set the stage here with my first few slides. So the average life expectancy for ALS is 2 to 5 years from the time of diagnosis. The literature shows a direct association between malnutrition and survival time. And there's increased survival with higher BMI, specifically BMI of 30 to 35. Goals of nutrition then are generally to maintain weight, obviously to get balanced and optimized nutrition and hydration. We want to try and preserve the social, cultural aspects of food and eating and quality of life as much as we can. So the known barriers, obviously, in ALS nutrition are many. So dysphagia, due to bulbar weakness, difficulty chewing and swallowing. There's hypermetabolism that occurs in patients with ALS. And the literature, has varied reports of incidents all the way from 20% to 65% of patients having hypermetabolism. Constipation is problematic and can affect appetite, depression, frontal temporal dementia, taste changes that can occur particularly later in the disease, upper extremity weakness, and then, just kind of other general issues like food insecurity, and of course, caregiver burden. Next slide. So our interventions then are calorie and protein dense food selection and supplementation, any texture modification that's needed, guided by the speech and language pathologist, increased meal frequency to overcome early satiety, support people offering feeding assistance and assistance with food preparation. Meals on Wheels can be helpful. Use of appetite stimulants where appropriate. And then what we are challenged with discussing today is feeding tube placement. So the feeding tube discussion and placement really, and the intervention is the word I'm struggling to find. The feeding tube intervention really requires a lot of key players, and the dietitian is the nutrition champion and very key in this process. But even within the multidisciplinary ALS clinics, there are multiple discussions centered around the feeding tube. So our speech therapist will discuss it in the context of swallowing function. Physical therapy and occupational therapy are often involved in discussions of how to manage this routine with the patient's deficits. A pharmacist involved in obviously making recommendations for what medications can be crushed and flushed versus changing medications. In my specific clinic, and I'm aware that this can definitely vary for everyone, for other institutions and healthcare systems, but in my clinic, our neurologists discuss the feeding tube as an intervention at the initial visit with the patient when they receive the diagnosis of ALS. So the discussion is started by the neurologist and it is continued in the clinic at follow-up care. Respiratory therapy will do pulmonary function tests, as you're aware, and that number is a good reference point for strength and life expectancy. Our nurse, social work, and then we also have our ALS association chapter representative come to our multidisciplinary clinics too. So oftentimes they'll be involved in discussing feeding tubes as well. Next slide. So outside of the clinic, then we will place referrals. So that involves scheduling. So are there issues with scheduling? Is there any area that we can improve the communication there if we're seeing there's a delay in getting in with the other clinics? So we'll refer to pulmonary. Sometimes our patients opt to go to a pulmonologist that's closer to home rather within our healthcare system, and that can have its own kind of trials if you can't really see the information from the outside the healthcare system to inform where they're at with their pulmonary function. Again, referring out to the team that's placing the tube. This can even vary with healthcare systems. In my system at Freighter, our ALS team refers to our gastroenterology team, who then will assess the patient for PEG placement and move forward with PEG placement. If they find that it would be too high risk, they would then refer to interventional radiology, who would then radioactively place the Gtube in IR. Some other healthcare systems I know, having talked to other dietitians, go straight to general surgery for G2 placement. Ever since the pandemic, we have become adapted to doing outpatient G2 and PEG tube placements. Prior to the pandemic, every ALS patient was admitted to the hospital for PEG placement or G2 placement. So that kind of, the pandemic kind of forced us to evolve there. Now, if a patient is determined to be too high risk, they will be admitted for PEG placement to have that additional support. So then communication needs to be clear with even more people, the inpatient team, and all that encompasses. Then, of course, we have to communicate with orders to supply company, the DME company, and we have to acknowledge the criteria from insurance as well. So the most key player in this, the feeding tube intervention is, of course, the patient. So I think it's imperative that the dietitian in the ALS clinic really truly educates the patient on all aspects of the feeding tube ahead of them making that decision. So as I had said before, in my clinic, our neurologist will introduce the concept, but really they're not going into the ins and outs of life with the feeding tube. So it's on us dietitians to support our patients in making their decision, whatever it may be. So indications for starting that discussion, if the patient is starting to lose weight, or if they have been diagnosed with malnutrition, dysphagia, prolonged meal times. If they opt to have a trach placed, then they'll have a PEG placed. If their quality of life is reduced by the time and effort needed to consume meals by mouth. So for years, the pulmonary function threshold of 50% was used to indicate safety of tube placement. But there's been more recent literature that supports safe placement with forced vital capacity less than 50%. And I did include those references towards the end of my slides, if you'd like to have a look. And even with in our own institution, I know they've been placing the tubes at much lower, like 40s. And so the European guidelines, the European guidelines released last year now recommend the use of non-invasive ventilation during G2 placement for those with compromised pulmonary function, and they don't even mention the threshold of 50% in those guidelines. Next slide. So back to the patient education. So I mean, I feel like the patient knowledge of what a tube is and understanding of how it would be used in their life is really important for smooth coordination throughout the PEG placement intervention. So in clinic, I will discuss with the patient what a tube looks like, and this may be different at your institution than mine. Like I had mentioned, we primarily do PEG placement. So as you can see in the picture on the right, that's like the internal bumper and external bumper, versus if they were to go to IR and get a G-tube radiologically inserted X-ray guided G-tube, that's going to have the balloon on the interior. And what the end of that tube looks like in the picture on the left, these button tubes will have 3 ports. Which may be confusing to the patient. So it would be good information to know that ahead of time, that there are 3 ports, and the one marked for feeding versus medicine versus this is for the replacement of the tube and inflation to keep it in place. Next slide. We also go into detail in clinic, discussion with the patient and family on what a day could look like for them with the feeding tube, the varying methods of feedings, whether it be syringe, gravity, pump, what's going to work best for them. If their plan is to have the tube placed prophylactically and continue an oral diet and maybe start supplementing, like potentially starting supplementation with over-the-counter products, depending on insurance coverage. I always like to provide a detailed plan, a written plan for the patient and family, so they have a reference. Because, as I'm sure you found too, this discussion and education could occur long before the PEG procedure is scheduled and placed. So we do provide printed summary of the education, and then also contacts, who to contact, when, in what circumstance. I generally don't go into the use of the pump too in depth in clinic, unless we anticipate they're gonna have a pump and a schedule, and then we'll give them a suggested schedule and rate and hours of infusion, that kind of thing. But then the use of the pump is the education for that is provided by the medical supply company. A nurse usually will come out from them to educate the patient in their home on how to use the specific pump that they supply. Next slide. Patients will often ask, what do I pour through there? So that's good to know ahead of time. I have encountered some patients will want to do their own home blenderized feedings, and I know that this education series, there's going to be a session specifically dedicated to blenderized feedings next month, so I'll leave the nitty-gritty of that till then. But just to talk through like the different kinds of formula with the patient and family, and identify who's going to actually administer the feedings. Is it going to be the patient or caregiver? Would ordering gravity supplies be easier and reduce caregiver burden rather than doing syringe feedings? Or sometimes people don't like the time it takes. I do inform the patient of what happens, how and who is going to order the formula, usually me. And I let them know that I'll send the orders to the company. They should expect a call from the company. I'll give them the name of who's supplying their formula. If it's a patient that's nonverbal, I'll ask who the point of contact is going to be, because the DMA company is going to want to call to arrange delivery and explain insurance coverage to you. If formula is not, I will explain insurance coverage to a degree with the patient. Obviously, we don't know the specifics of coverage for every insurance plan out there, but I'll do the best I can, and obviously have a better knowledge of Medicare coverage, because the majority of patients I see in ALS clinic have Medicare. And if the formula is not covered, I'll tell them like what alternatives we may have then. So who is the designated team member to educate and support this? Us, the dietitians. Next slide. So I just included one slide here on Medicare guidelines, because they have changed in recent years, and I still do find myself encountering pushback at some DME companies where they're referencing older Medicare guidelines. So I think it's on us to really be in the know of what's current. So it still requires general documentation, physician's orders. The documentation should show permanence, which is defined as greater than 90 days. And then this tagline here, show disease or dysfunction of the structures that normally permit food, and so on. I mean, I've talked with some dietitians that just copy that, put it in their note, and they do just fine then with insurance coverage. Some of the things that have changed in recent years are that EN does not have to be the sole source of nutrition. That's not mentioned in the Medicare guidelines. And a specialty formula is covered without having to document failed therapy, failure of standard formulas. And well, this remains the same, that a feeding tube pump needs to be justified with failure of other methods. So inability to tolerate the bolus feedings. Right. So then that's that. So far we've coordinated within the ALS clinic and identified, the multiple disciplines that are involved in the feeding tube discussion there. I would say primarily the dietitian. And so let's move outside of the clinic. And this will vary, like I said, with your healthcare system. We'll refer, the patient has decided to move forward with the feeding tube. We'll refer them to the gastroenterology clinic, who will and their scheduling team will set up an appointment for evaluation. So they'll meet with the gastroenterologist or their physician's assistant, and then based on that visit, move forward from there to schedule the actual procedure. In my system, the post-procedural care is the peg is placed the one day, and then the following day the patient has to come back and meet with the GI nurse for a bumper check. So sometimes the ALS dietitian work doesn't stay within the clinic, right? The timing doesn't work out between our assessment and when the patient actually decides to move forward with and get scheduled for placement. So at times I'm asked to call the patients to complete a nutrition risk assessment. And at that time, assess for refeeding risk. Do we need to get labs? Do we need to admit for electrolyte supplementation and start the feedings at a slower rate? Or, does everything nutrition seem good enough to move forward with peg placement? And then I will document and use that documentation to place the tube feeding orders. In your clinic, it's good to consider who is the person responsible for entering orders and faxing orders. I personally enter my own orders and I fax them, but in other clinics that may not be the case. Is this an area where there's a holdup or a delay if we're waiting on somebody else to do some of these things? I learned over the years that it's best to just provide a direct callback number to the DME company when you're sending in the orders. They need to have somebody to call to answer who's knowledgeable and can answer questions on the documentation if it meets the insurance guidelines, or somebody who can give recommendations on what a substitute formula if there's shortages. hopefully not. Hopefully we're done with that. Or are there other dietitians in other clinics? We've recently had dietitians added to our GI clinic that are involved also, or if they're inpatient, who's coordinating that. Also, if the feeding tube is placed at another facility or a hospital closer to the patient's home, who is going to make sure the patient has orders then for following the procedure? Is it going to be a dietitian or team there at that local hospital, or is it going to be me? All right, next slide. So we have a few years back we developed a handout with the GI team to give to our patients that like outlines everything that I just talked about with what feedings could look like and so on. And there's an area to provide a suggested schedule for the patient. And then at the end, we added contact numbers, who to contact when. Like if you have issues with your hardware, we like to say like if the tube is leaking or cracked, who are you going to call? So they'll follow up with the GI clinic, or who's going to replace those low profile tubes. Is it going to be GI? Is it going to be IR? I have had patients that replace them themselves at home. And if there's issues with formula tolerance, who are you going to call? Hopefully me, right? So that's who's listed on the materials. Also, we have guidelines in there for when to go to the ER. If there's supply issues, delivery issues, they should communicate that to the supply company, the DME. So, so I would encourage you to also kind of review the process in your specific healthcare systems. You know, if you've had difficulties with or hiccups with the coordination of care surrounding the tube, it's good to really dig into that and figure out if it's repetitive, and if it's an area that needs to be addressed and corrected, and then it will be smoother for patients going forward. So so one suggestion is to generate a checklist of touch points. I know Stephanie Dobak shared with me previously that she and her surgeon like developed a document where they outlined exactly who was involved in care and when, and who was responsible for that aspect of care. And she's found that useful. Essentially, what we're looking at is quality improvement, right? And so I just kind of included some information on that here. And the quality improvement process really it involves several steps. So first you identify what the issue is, then you plan what your intervention is going to be to address that, then you assess how that went, and then use that to change the process. And it's an ongoing cycle because things change. Even staff turnover in any of these key areas that we've just talked about, these healthcare teams, can really upset the apple cart a little bit. So, so quality improvement is definitely an ongoing process. Next slide. So, some things I feel like we're close to discussion part of our presentation here, but some of the things that I can share at my facility. So for the longest time, I was the dietitian in ALS clinic, and I would collaborate with the GI providers for ordering the supplies and formula and such. I was the person that was doing the ordering. But the GI clinic has grown over the years, so they've added dietitians, which is awesome. But then it ended up being, there was a couple of instances where, you know, there was a delay in orders because one dietitian thought the other dietitian was placing the orders. So we had to develop a system of who's doing it and when, right? So our solution to that was I would place the orders if I was the last person that had done a nutrition assessment. If the patient was getting it prophylactically and no orders were placed at the time, of PEG placement, then they see me or they call me because they have my contact information. The patient has my contact information. So then I will do orders then. Or if it's the case where the patient is seen in the GI clinic, seen by their dietitian, moving ahead with placement right away, then they've been placing those orders. I also, over time, had noticed that patients, when we had sent them to outside facilities, or the patient had opted to have the tube placed closer to home, sometimes they were getting the tube and then sent on their way. There was no orders or anything. So I had just, that adjusted my patient education, uh, so the patients know to call me if they're first of all, when they meet with the proceduralist, to ask if they're going to place the orders, and then if they have clarification that that's not going to happen, then they know to call me. And then the other example I had was for contacting patients to identify somebody that can advocate for them over the phone with the DME. So yeah, that kind of that's where I'm going to leave my slides today. I do have a couple of reference slides here at the end, but I'm hoping that some of you can offer examples of areas to troubleshoot also.
Well, thank you, Michelle, for the presentation. I'm going to go ahead and stop the recording.